Thanks everyone for joining. We're just going to give it a few seconds for everyone to get in. Okay, let's get started. Welcome to this year's MyIBD Learning Virtual Program promoting IBD independence in children and teens. My name is Ria Bahadur. I'm a patient myself, and I'm a current sophomore at UC Berkeley and an NCCL member. So along with our regular MyIBD learning programs, this year we're going to have two programs focused on pediatric topics. Tonight's pediatric program is focusing on the transitional phase from childhood to adulthood. It's important for children and teens to become self-advocates regarding their IBD care. Tonight, you will hear from a pediatric gastroenterologist and psychologist on how to gain independence and where to find support during this phase of life. In order to make the program more interactive and find out how much you've learned tonight, we'll be asking two questions via a poll on your screen now. Okay, so let's start with tonight's first question. What is the ideal age you should start transitioning for your child? Directly underneath you'll find our second question. Who is ultimately responsible for taking medications? So let's everyone take a second to make your selections now. Okay, thank you guys for your participation. It looks like most people selected age 12, but there's a very close tie with age 15 for the first question. And for the second one, it looks like most people selected your child or teen. Oh, actually, no, they selected it's a shared responsibility for question two. So let's listen into the following presentations to learn more. And on behalf of the Crohn's and Colitis Foundation, thank you all for joining. So the information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. This program will be recorded and posted on the MyIBD Learning website. So that's going to be at crohnscolitisfoundation.org/myibdlearning. And everyone who registered for the program will also receive a link with the recording next week. We want this to be as interactive and engaging for you, so we encourage you to submit your questions through the Q&A box, which you can find the lower part of your screen. And then following our expert discussion, I will moderate a Q&A session with all of our panelists, and we'll address as many questions as we can with the time. So for tonight's speakers, our two expert presenters tonight are Dr. Shelley Dykes and Dr. Tina Holbein. Dr. Shelley Dykes is the medical director for the Inflammatory Bowel Disease Program at GI Care for Kids/Children's Healthcare of Atlanta, Scottish Rite. She started her clinical career at Cincinnati Children's, where she was the director of quality improvement for 5 years before moving to Atlanta. She now leads the quality improvement work at GI Care for Kids through Improve Care Now, an international improvement collaborative aimed at improving outcomes for children with IBD. She serves as medical director for Camp Oasis, Georgia, and at home, she is the mother to 2 children and enjoys spending as much time outside as possible. Dr. Tina Holbein completed her graduate training in clinical pediatric psychology at Loyola University Chicago. During her pediatric psychology internship at Nemours AI DuPont Hospital for Children in Wilmington, Delaware, she specialized in a year-long gastroenterology rotation. Dr. Holbein completed a T32 fellowship at Cincinnati Children's Hospital Medical Center's Center for Treatment Adherence and Self-Management, where she gained research and clinical training in condition self-management, mental health interventions, and transition to adult care. Since 2018, Dr. Holbein has worked as a clinical psychologist embedded within the GI division at the Children's Hospital of Philadelphia, where she has dedicated research and clinical time within the Center for Pediatric IBD. She has also volunteered as a mental health volunteer at Camp Oasis since 2019. We understand the importance of your questions and want to ensure we answer as many of your questions as possible. Tonight, we have the honor of having Dr. Jennifer Stropel monitoring the Q&A box. Dr. Jen Stropel obtained her medical degree from the University of Alabama at Birmingham and completed her pediatric residency and gastroenterology fellowship at Cincinnati's Children's Hospital Medical Center. During her fellowship, Dr. Stropel obtained her master's in epidemiology from the University of Cincinnati. Dr. Stropel joined the Northwestern Feinberg School of Medicine in 2004 and is currently an associate professor in pediatrics. In addition, she is the physician leader for Lurie Children's in the Improve Care Now network, and also the primary investigator for several clinical research studies that focus on advancing the understanding of these complex diseases. In addition, her clinical and research endeavors, Dr. Stropel currently serves as the program director for the Pediatric Gastroenterology Fellowship at Lurie Children's and is the co-director of the Office of Fellowship Programs for the Department of Pediatrics. If you have a question for Jen, please type it into the Q&A box. She will do her very best to answer as many questions as she can, keeping in mind she may not be able to address every single one. Following the conversation with Shelley and Tina, Jen will join the group for a live Q&A session. And at this time, there are no disclosures from our presenters tonight. Okay, now let's get started with tonight's conversation on promoting IBD independence in children and teens. At this time, I'd like to introduce our first expert, Dr. Shelley Dykes.
Hi, everybody. Thank you so much for joining. I'm so excited to share with you today. So pediatrics is all about change. From the time that we meet our patients to the time they leave our practice, everything changes. We're watching our patients grow physically, intellectually, psychologically, and part of that means building independence over time and ultimately finding ways to help them transition to adulthood. There are also social interactions that happen. And so basically nothing is the same, which is part of why many of us go into pediatrics. It's fun to see people grow and develop and do all the things that they're supposed to do, but it's also a challenging time for patients and their families when they're going through all of these different changes. And as we all know, change is hard. And at first it can be messy in the middle, and then gorgeous at the end. So, as a quality improvement leader, a lot of what we do is trying to help with change, but a lot of change happens on its own. And so part of this process is trying to make it look better and work better in a way that helps and doesn't hinder development or progress. And I think that there are those among us that kind of just look at things and say, well, what if we don't change and we just wait for something magical? And we all know that realistically, that's not how it goes. So for most of our lives, you have to plan, you have to figure out how to try to help things move along. And transitioning from pediatric practice to adult practice isn't something that you just all of a sudden go to the adult world and expect it to work. It's better if there is a plan and that we give people skills to try to make things better for them after they transition to adult practice. So first, before we really truly get started, it's important to clarify the difference between transition and transfer. So transition is meant to be a process. It's a purposeful, planned effort to help prepare a patient and their family to move from pediatrics to adults. So more of a caregiver-directed role to more self-management. Transfer is the physical act of going to adult medicine. So the process is really the bulk of what the work is. And it does continue after you transition to adult medicine. It's not a, once you're there, it's golden. There is some ongoing work to try to continue that process after you go to the adult world. So barriers that we see. So on a patient and family side, there's a lot of disease knowledge and understanding that has to happen. So especially for our younger kids who are diagnosed very small, they grow up knowing that they have this chronic disease. And so sometimes there's some re-education that has to happen as they get older, because they don't always understand the rationale or what they have. They don't necessarily remember some of the things that happened when they were younger. And so there is a pretty significant re-education process that has to happen for some of our younger kids. Adult doctors are different. And so there's definitely a comfort thing that changes when you go from somebody who you've been with during childhood to all of a sudden this person who steps in and you have to have a new relationship with them. We do find that insurance gaps and coverage of visits and medications changes things too. And so that creates some barriers to a successful transition sometimes. And then work schedules, school schedules, the process of graduating from high school, going to college, going to vocational training, working, all that stuff makes it trickier to try to do all the things that we need to do to help transition people effectively. And for a lot of our patients that we take care of, if they move far away from college, trying to figure out how to help them do that either during college or when they're home gets tricky too. And then on a physician side, we all know how it's been to try to get records sent effectively. So sometimes we don't get all the records. They say they're sent, you don't have them, and you show up at a doctor's office and they don't have everything you need, which leads to an incomplete transfer. Adult practices are different than pediatric doctor's offices. So who you call, how you call, what the nursing structure looks like, who they're wanting to talk to is different. In pediatrics, we usually will talk to the parents more, especially for younger families, versus adults. They want to talk to the patient. They don't want to talk to parents. And appointments are different. So how we work people in is sometimes different than in adult practices. And so all of those things can sometimes create barriers for a successful transition and transfer process. So when should transition start? So some of this depends on the child. And my practice is to try to start talking about transition as early as possible, just to try to practice some of those skills before you actually need it. So realistically, about age 12 or sometime in middle school for developmentally typical kids is usually a good target. And realistically, our goal is aimed at patients, but is a whole family process. And so if a parent isn't engaged in the transfer process and transition process, sometimes that makes it harder for the kids. So we do need buy-in from both the patients and the parents. And so most of the stuff that we talk about in the office in terms of transition doesn't actually happen in the office. It's stuff that gets practiced outside of the clinic. And it's what Tina will kind of help us learn a little bit about later, because I talk about in the office, but the work of most of this actually happens outside of the office. So how does this happen? There are different models. Some groups have true transition clinics where you will meet your future doctor at clinic, and they have planned clinics with the adult provider where it's sort of like a slow roll transfer process. There are some groups that have transition facilitators where they have a nurse or social worker or a PA or nurse practitioner who may come and kind of go over some of the things that need to be worked on for transition with the patient and family. And then in some offices, it's an MD or clinic-led approach where it's focused with the doctor. And to be perfectly honest, some clinics have more just a may the odds be ever in your favor approach. And that's generally not what we want. We don't want to just turn you loose into the world. We want you to have the skills you need to be able to have a successful transfer. So which one is best? It's hard to say. There's been a lot of research looking at all these different processes, but whatever happens, the goal is to have a planned process. So it's not just sending you off into the world, because we know that having a planned process does improve patient perception of the transfer, as well as how well people continue to follow up after transfer, because we want you to continue to do well after you go to the adult world. There are lots of metrics that have been looked at, including quality of life, disease-specific outcomes, how well people are doing medically, how well people continue to take their medicines, and readiness for transfer. But again, it's hard to say that one effort is better than the other as long as there's a process. Usually things are fairly similar. So what things will we work on during transition? So the easy one, the low-hanging fruit, is disease knowledge. So what disease do I have? Where is my disease? When was I diagnosed? Things like that. Knowledge related to medications. What are my medicines? How often do I take them? What do they do? What are the side effects? What are the procedures that typically I will be talking about? What are these lab tests? What do these things mean? Basic medical knowledge. What are the parts of my GI tract? What do they do? Things like that. And then beyond the medical stuff is, how do I take care of myself? How do I plan things like insurance? How do I make sure that I have refills? How do I schedule visits? And then overall health and lifestyle. How do I make sure that I'm taking care of myself, keeping myself healthy beyond just my IBD? And that includes both mental and physical health, as well as social health. So around age 12 to 14, this is usually when I start to talk about transition with my families and my patients. And as I said before, a lot of times for my kids who are diagnosed very small, we start basic. What disease do you have? Why do we do this stuff? Do you remember what your symptoms were when you were diagnosed? Because a lot of people don't remember feeling bad when they were diagnosed. And so recognizing the importance of keeping on taking their medications is important. They may not remember how bad they felt before. So it is important to talk about what happens if you don't take medicines and things like that, and what the disease can do if it's under controlled. And in this age group, it's also sometimes just about encouraging independence at school, encouraging independence in the office. How do you talk to your friends about your disease? How do you talk to your teachers about your disease? How do you advocate for yourself if you have an issue and need to have a special situation? Being able to talk to the doctor when they come in, knowing your medical team and being able to talk about what your symptoms are on a daily basis are all important. So in this phase, a lot of times I will ask my patients to plan for their next visit. So I will always plan for their visits when they come in, and I will already know when they come in, we're do these labs, we're do this test, that way I have more time to talk to them during the visit. And I will ask them to bring a question the next time that they come in. If they don't have a question, bring a joke. And I start that when they're small too. If you don't have a question, bring a joke, so that we have that interaction that we can plan so that it's not so scary. And then around ages 14 to 17, this is really when we're asking kids to start doing more of the work. What are the tests? We turn the computer around, look at it so that they know what the tests are, why we do them, how often we do them, what do the results mean. Really digging down into personal history and, what makes me feel bad, what doesn't make me feel bad. I like to encourage people to practice refilling medications and beginner insurance stuff, because the insurance process is painful for patients and for on the medical side, and trying to practice some of that as early as possible can be helpful. Just knowing I need to have this information. These are the questions they're going to ask me. And then as patients get older, being able to practice more time with the doctor alone during the visit, especially after age 16, 17, is helpful. And then as time goes by, we want to also talk about things other than IBD that can affect health, things like drugs, alcohol. If we don't take medicines, what happens? And then we start to get into things too, in terms of what do parents absolutely need to know, safety things like if there are things that are personal danger for the patient or someone else, what do they have to know versus what do we want them to know? We talk about sexuality, fertility, what are things that we need to think about with the different medications and disease-specific things that might affect people later on for family planning purposes. And then we do talk about longer goals. What are we doing when we graduate from high school? Are we going to work? Are we doing vocational training? Are we moving away? Just so that we can try to start to plan for what we might need to encounter over the next few years. And then after about age 17, this is when we want kids to ideally be able to take more personal responsibility. So we're going to dig down deeper into those medications. Which ones are ones that you shouldn't take together? What are ones that might interact with alcohol or other drugs? And then what happens when you turn 18? What happens when you move away from home? Who can we call? Who can't we call? How do you do things on your own? What happens when you're away from the house? And by this age, we're really wanting to encourage people to be able to assume more of their daily medical care, calling for refills, appointments, understanding lab results, more of their insurance information, being able to call the nurse when they have an issue, and being able to communicate symptoms directly to us rather than us having to talk to the parents, so that we get more information straight from the patient rather than playing a literal game of telephone. And then, when people turn 18, sometimes insurance changes. And so we want to plan around 18 plus, at least for the next couple of years. How long can we stay on parents' insurance, or does our insurance stop at 19? So what's going to be our next step for insurance coverage? And this is when we really start to need to practice taking our information around with us in our wallet. And viewing what happens if we don't stay. Sometimes that's when we start to forget to take things because we're feeling really well. And so it's hard sometimes to remember to keep taking or coming back. Next slide. All right, so next step. So the first step really truly is just to take a deep breath. This process doesn't happen overnight. It is a work in progress, and we never expect someone to do all of the things on the list at any one visit. Many centers don't have a defined transition program, but there are lots of resources. In our clinic, we don't have the benefit of having a transition coordinator. We don't have a special person who can do all of the things that we talked about. So for us, it's, I have a list of things and we talk about it at every visit. And so we try to spend as much time during the visit talking directly to the patient about the things that they want to work on for the next visit. And that's patient and family specific. So, what works for you may be different than someone else. So what you may want to work on may be knowing what your labs are and what they do. Other people may want to practice refills. And all of those things are important, and nothing is better than the other ones as long as eventually we work on most of them. And then options like Camp Oasis are things that are good options just to practice some independence away from home. And it's so much fun to see campers come in who swore that they would never be able to give their shots or do other stuff, and seeing other campers be able to do stuff like that has led to a lot of new skills and new comfort, new knowledge. And it is really helpful to be able to learn and see other kids doing things that they may want to try as well. So camp is an excellent place to practice some of those skills and really have some independent time. So if that hasn't been something you've considered, that's a great way to start to practice some of these independent moments.
Thank you so much, Dr. Dykes, for sharing this presentation with us. We certainly learned a lot about how transfer is different than transition and how transition looks differently at different ages. As a reminder, you'll have a chance to address questions to tonight's speakers, so please make sure to place them in the Q&A box below. Okay, and then next, I'd like to welcome Dr. Tina Holbein.
Hi, everyone. Welcome. I'm really excited to, move forward from what Dr. Dykes was sharing and talk a little bit about how we can actually start working on some of these independent skills away from clinic. So, as a behavioral health provider, I can't talk about self-management and independence without acknowledging that there are lots of feelings on all the sides. And so, of course, we know that caregivers and kids or teens alike may be feeling some level of anxiety. We're trying some new things, we're having to put some trust in each other. And for parents, of course, there's that lack of control or that trust that we're putting in a child or a teen to take some more responsibility with, one of the arguably most important things in life, right, which is their health. Of course, there can be some frustration in the mix, right? If some things don't go as planned, or if we're getting reminders that we don't feel like getting, or, just those kinds of things that can be challenging. So, of course, frustration can be a piece of some of this experience. But we also know that with some of these, challenging feelings, we can also experience a lot of excitement and pride and accomplishment. So, of course, it's awesome to be able to see kids and teens taking steps forward and trying something new or taking responsibility for something that they haven't done before. And of course, both them and caregivers feel so proud of those steps. So one thing I often think about, right? I often catch myself asking families, who's responsible for, insert medical task here, right? So in this case, we might say taking medications. And, it's really, I get different answers depending on who I'm asking. So caregivers might say, well, I'm responsible because I'm the one that is, contacting the pharmacy and dealing with the prior auths and filling the pill organizer and giving reminders. But then when I ask kids or teens, they'll say, well, I do it. I go over to my, pill organizer. I take my pills every day. I try to remember them on my own. And so it's really me. And obviously this can be confusing, right? Who is actually responsible for some of these tasks? So we know that rather than thinking about it as one or the other, I think it can be really helpful to consider this transfer of responsibilities as more of a continuum or more of a spectrum. And so typically we're really sharing a lot of those responsibilities, especially for kids and teens. And we think about in the transition process, going from taking a responsibility that a caregiver may be in charge of and gradually shifting that responsibility more towards the child or the teen. Of course, we know that it doesn't always move in this really smooth linear direction. And it's actually really common at times for a child or a teen to, maybe bite off more than they can chew or to set an independence goal that, might not be the right time or they're, a small enough goal to work on. And a caregiver may need to be more involved for a little while until we're ready to try again. So it's really common to have to kind of navigate this shared responsibility in different directions. And of course, we know too that even though there may be times where a teen or a young adult may be responsible for many things and able to do many things, that in some cases too, it's having conversations as a family about ways that caregivers can still stay involved and may be able to take one or two things off of a teen or a young adult's plate. So Dr. Dykes did such a fantastic job of outlining some of the guidelines that we think about for different goals based on age. But one thing that we know is that sometimes we have to be flexible, right? It's all about flexibility. And so there's a few factors that I wanted to review that may help you if you're thinking about modifying what kind of goals you're working on or where you're at in this process. So one factor is really considering, a child or teenager's development. So we know that for young people who experience attention difficulties or executive functioning difficulties, if there's a young person who's maybe just a little bit slower to mature or may have characteristics or diagnosis of neurodiversity, that we may be taking our self-management and independence goals at just a different trajectory. We still have expectations for growth in these areas, of course, but we might just, set some different goals or go at a different pace. And then we also consider emotional functioning. Of course, if a young person is experiencing anxiety or mood concerns or other emotional challenges, we might be a little bit more flexible in what goals we're working on or what pace we're working on. And then we also want to think about where you're at in your IBD journey. So there may be somebody who is an older teen or even approaching young adulthood who's recently been diagnosed and might not be ready for all of those characteristics all at the same time, right? And so we might need some more time to adjust and some more, kind of thinking about where we want to go and building independence. And similar to what Dr. Dyke shared, sometimes we may assume that children who are diagnosed earlier in childhood are going to be a step ahead or are going to be ready to take on their independence goals really quickly. But we know that sometimes you actually need a little bit more support because caregivers and medical providers can, kind of fall into these really comfortable habits of doing a lot of the conversations and decision making together without necessarily looping in or educating the child. And so, we want to be thoughtful about where we're at in that IBD journey. And then we know that healthcare barriers are a big piece. And I know that Dr. Dykes mentioned this too. So insurance barriers, difficulties, attending appointments or accessing care, difficulties communicating with your medical provider or forming a supportive relationship with your GI team can all be things that might just have us adjusting our timelines a little bit or, thinking about where we want to go next. Um, there's just a few things that I think help us to know when we really want to proceed with some caution. So the first is as far as setting new self-management goals. So the first is probably a little bit self-explanatory, but if a child or teen is in the middle of a flare, and treatment plans may be changing a little bit more quickly than usual, not feeling their best, this is a stressful time for everyone and may not be the best time to be setting a bunch of new independence goals. So when possible, we really want to try to wait for symptoms and treatment plans to stabilize before we're trying new things. The other thing that I think can be helpful to keep in mind for, proceeding with caution with our self-management goals are big life changes. So, we know that big life changes often mean we're just trying to figure out, how to put one foot in front of the other and do the things we normally do. And sometimes, dealing with some pretty big feelings as well. And so when possible, it can be helpful to wait until life kind of levels out a little bit and we're able to start working on our independence goals again. I also consider too that, sometimes families will come to me and have a really time-sensitive goal that they're working on. And for some young people and their families, this gives them a little bit of that oomph or motivation to take us, go a step further than they were at. But on the flip side, it can also be a time where we're kind of increasing the stakes and adding some stress, and making things a little bit more challenging and stressful. And so I think one of the common ones I might encounter are 17 or 18-year-olds who are just about to head off to college and might come and say, I need to learn how to give my own shots, and I only have a month. And so, we just want to be cautious about setting goals that feel realistic and helpful and don't feel too stressful right from the start. So as a sports fan, I love the phrase trust the process, but we can use that really here too. And, as I think we're both emphasizing tonight, transition and self-management really is a process and a team approach. So if you're thinking about where do we go from here? How do we actually set some of these goals and how do we work on them? The first thing is really having conversations together as a family. And making sure that we're on the same page and that we're picking self-management or independence goals that feel relevant and feel feasible. We, really only want to go with one or two goals at a time because, trying new things, on top of getting through just the everyday life can be a lot. So, slow and steady can win the race. We don't need to do all the goals at one time. Once we've decided what goal we're going to work on, we can break it down into some smaller steps and really create the plan. I have a process that I'll share here in a second too that might help us think about how we break this up a little bit more. So the first step is really making it an observation. So this may be the child or the teen or the young adult observing. And I like to say that we really want this to be intentional. So a lot of times when we talk about this with families, a caregiver may say to me, well, they say you do this stuff all the time. But the thing is that we might not always know if a child or a teen is actually paying attention and following the plan. And so we can be intentional and say, hey, I want you to learn how to, fill your pill box independently. Here, come over and sit next to me, and we're going to do this together. You can watch me this first time. And then we really want to explain the steps. It might seem kind of silly. It might seem like it's obvious, but I think it's really important to know why we're doing some of those steps or, some of the things that we've learned along the way. After we've done some observations, then we can really think about shifting some of those responsibilities from caregiver to child or teen. And so this really gives us a chance to do the task together, whether that's sharing some different parts of the task, or whether that means kind of gradually shifting independence over time. And then after we've gotten some practice doing it together and the child or teen has shown some growth in that area, even if they're still pretty independent and able to do a lot on their own, we still want to have that safety net of monitoring and, offering support as needed. So this might be things like checking to make sure that a task has been completed or giving some reminders here and there, or even just having a conversation, to see how it's going. But we go at our own pace for this process. So there's no specific guideline of, well, you need to observe once and do it together 5 times or anything like that. We know that depending on the goal that you're working on and what other things might be going on in life, some steps might take a little bit of time and others might be pretty swift or quick. So it's really adapting this to what works best for you and for your family. So how might we see this in action if we were to actually try this? So a really common goal that Dr. Dykes mentioned earlier is increasing independence and communicating with the medical provider. And one way we might do that is through a patient portal. And so the first time the caregiver might approach their teen and say, hey, I'd really like you to join me that next time I have a message to send to your GI doctor. So, come sit next to me. I'm going to show you how I log into the patient portal and how I send the message. And then, the caregiver really outlines the steps, like this is how I log in. This is how I find the message, compose a message section. This is how I find your doctor's name in the dropdown, and so forth. The next times that we have to send messages to the GI doctor, we make this more of a collaborative process. So maybe next time the teen is kind of the keyboard and mouse clicker and is like going through the patient portal, but we're really writing the message together. And as we go forward, it might be a little bit more independent each time. So maybe the next time the teen gets the message set up independently and then the parent joins and we work on the message together. Once we feel like the teen is in that space where they're independently able to use the portal, they're composing the message, they're ready to go, we might have the parent or caregiver double check the message before we send it, or even in some cases, check afterwards and say, oh, I saw that you sent the message to Dr. So-and-so, really great job, and give some positive feedback. One of the biggest parts of this process, though, is we really want to stay positive. Like we said, there can be frustration, there can be stress or anxiety with this transition process at times, and staying positive is so key. So I'm all about celebrating even the smallest wins. So even if a caregiver notices that a child or teen maybe answered a question independently at their medical visit, or maybe they actually remember their nighttime meds on their own without needing a reminder one night. These are opportunities to give some props and some positive feedback. And then if it's a little bit of a bigger goal that we've been working on, right, like giving her an injection or managing an aspect of ostomy care independently, this might be a little bit of a bigger celebration or a reason to celebrate with some more recognition. So setting independence goals is, of course, a really individual process, and it really depends on what a treatment plan looks like, what your goals are, and where you're at in the process. But I have 3 strategies just for some inspiration here that I find myself commonly recommending to patients and families that I work with. So the first is using a pill box. I am a huge fan of pill boxes, even if we have really young kids. They can start to see from an early age that organizing medications can be really helpful and, can join us or sit next to us while we're filling the pill organizer. But for teens, this is one of my favorite things. And, I have many teens that will express some frustration that they're really good at reminding themselves to take their medication and they don't like it when they get reminders when they don't need them. And yet we know that sometimes reminders are still helpful. And so pill boxes are a really great way for teens to be taking some independence and taking their medications independently, staying organized. And then if a caregiver sees that the medication that was due next hasn't been completed, they can just, really easily give that reminder only when we need it, or maybe even just bring the pill box over, right? Because the child or teen knows what to do. Another thing that I think can be really helpful that goes along the lines of communicating independently with the medical provider is signing up for a patient portal. So, many practices use some kind of online patient portal. And, depending on age limits, teens can often get their own logins. So the age limits may vary. You'd want to see what age limit your practice or medical center uses. I know at ours it's 14. But go through the steps of making sure that a teenager has access to their patient portal, that they, have it bookmarked on their devices or have the app that they need to do, that they know even like how to navigate the patient portal. How do we find the most important stuff like the schedule or how to compose a message to our provider? So I think that this is a really big piece, especially since so much goes on these days in the patient portal. And if we want our, teens or young adults to be in the know, we want to make sure that they have access. And then, when we're considering meeting alone with a GI provider, Dr. Dykes gave some great examples of how to scaffold this even from a really young age. As we get into that teenage stage, even a few minutes is a great start. But I always like to mention this to caregivers too, because many of the teens that I meet with will share with me like, yeah, I'd really like to meet with my GI provider alone, but I'm a little bit afraid to say something in front of my parents or my caregivers because, I don't want to offend them or I don't want to have them be suspicious that I'm asking about stuff that they don't think I should be asking about. And so I think it can be really helpful to start the conversation as the caregiver. So, obviously we don't want to throw anyone into the lion's den or catch anyone unprepared, but we can talk ahead of, an upcoming visit to make sure that this is something that feels like a good time to try. And then consider how we might feel prepared. Maybe that means we're bringing a note card or taking some notes in the notes app on our phone that we want to make sure that we share. Or maybe we're just practicing like some common questions that we're used to and, doing some role plays with a child or a teen answering them on their own. So I hope this gives some inspiration here for taking some next steps. So even with, all of the guidance that we're sharing today, we know that there can be roadblocks along the way. And again, it's a pretty individualized process and it can be really helpful to know that there's more support out there. So where should you go if you're looking for more support? First and foremost, your GI team is a great place to start. Your GI team knows about your specific IBD plan and may have some really helpful tips or tricks of their, that they've already gleaned from experience, but they can also point you to resources or referrals that may be really helpful. One of those resources or referrals may be a social worker. So at many pediatric medical centers, they have medical social workers who have all kinds of responsibilities. And I can't even summarize all of the hats and roles that social workers may play. Social workers traditionally have a training or background in mental health. And so, they are often very helpful in navigating some of these challenges towards independence. Some of the ways that they may provide support in this transition plan are navigating barriers to care and different kinds of resources. So helping you to figure out what those insurance barriers are, helping to advocate with school and school accommodations, identifying any barriers to care that may have to do with transportation or cost. And some medical centers as well, social workers may have a role in transition itself. So they may help to provide referrals or kind of help you set some goals for how you can make that transfer to adult care. And then many medical providers also have a child life specialist team. And we often think about child life specialists as being, supports for our, younger patients and their families, but this is a really big part of self-management and independence too. As we've been talking about tonight, self-management and independence, a big foundation of that is having knowledge and education about your IBD and its treatment. And our child life specialists are awesome at helping to teach younger kids or older kids too, and their families developmentally appropriate ways to talk about their IBD and their treatment and to learn some basic coping strategies for their treatment, which is a big part in meeting their goals later on. As a behavioral health provider, we know that behavioral health providers can also play a role on the team when it comes to building independent skills. And a behavioral health provider can come from a range of training backgrounds or have a range of job titles. But one thing that all behavioral health providers have in common, well, there's actually two things that we have in common. One is that we tend to be experts in behavior change. A lot of people don't think about that when they think about a psychologist or a social worker or a therapist. But we have this background in behavior change, and independence and self-management is all about changing behaviors. So we can really use our tools in this way. We also have experience and training in helping families to communicate effectively. So again, if we know that this has, that there can be some big feelings here, or that, families are, trying to figure out how to make this a smooth process, this is also a place where we can really lend our training and background. An additional factor to consider as well that might be more of a side factor here is if we know that somebody is experiencing emotional concerns that are making it hard to set these self-management goals, a behavioral health provider can also provide support for helping with things like anxiety or depression or executive functioning and attention difficulties. And so really working on some of those factors so that eventually we can start working more on the self-management goals. If you're wondering how to find a provider, there are different ways that this can happen, but I think a really great place to start is checking in with your GI team or your primary care provider. So oftentimes they may have a referral list, or they may even have a relationship with local providers that they've worked with themselves, or that that they have patients who have reported some positive feedback about. So I think that can be a really great place to start. There's a really great resource guide by Improved Care Now that offers all kinds of information that has, about how to find a behavioral health provider in your community and, what you can do, the kinds of questions you might want to ask as you're getting started. And then, there are online directories that you can find. One example that's pretty well known is Psychology Today. Insurance companies also have their own directories as well. And so you can kind of combine lists. But I do think that one thing that I always look for when it comes to self-management and independent skills is finding somebody who has a background in cognitive behavioral work. And really, again, this is because we're working so much on behaviors. And so we want somebody who really has that expertise and experience in behavior change. And then college supports are huge. So if you have or are yourself a young person who's getting ready to go to college and you've made you've committed and you're ready to go, of course we know that independent skills don't just, we don't just, have to be 100% there by the time we step onto campus. The Office of Disability Services, it sometimes has some different titles or names, but the Office of Disability Services or Student Services is a great place to start, not just for transitioning any kind of academic accommodations and resources, but also to get a roadmap of the kinds of resources or supports that are available on campus. I have many college students who also find it really helpful to partner with their nutrition services team for any support in dietary accommodations or managing meal plans. And similarly, working with the residence life team find support to help it with independence and self-management in the dorms or student housing. And then wellness centers are great resources too. We might not always think about. Every college pretty much has a wellness center, and they can be helpful for you know providing support for some of the treatment aspects that we may not be independent with quite yet or are still working towards. So just as an example, we might have a college student who is going to their wellness center to get an injectable shot done if they're still working on building the confidence to do it independently. And of course, wellness centers also often have counseling services built in, which can be an additional support if we're working on some of those goals. So I think we really want everyone to know too that, although this is, we can make a lot of progress on our own, there is so much support out there to help you in gaining independence and navigating this process. All right. Thanks so much.
Thank you so much to Dr. Holbein and Dr. Dykes for wonderful presentations. We hope you all feel more empowered regarding you or your loved one's IBD care. So while we are gathering questions from the Q&A box, we'd like to resubmit the 2 questions from the beginning to see how much you've learned. So at this time, please make your selection to the 2 questions on your screen now. Okay, this is great. The correct answer to the ideal age to start transitioning is age 12. And the correct answer for the second question is that it is a shared responsibility. So thank you all for taking the time to participate in this polls. And now we can take some direct questions from our audience. I'd like to welcome Jennifer Stropel onto camera, who has been answering questions for us throughout the chat. So let's now direct a few of the audience's questions live to our expert presenters. And if you have a question for anyone, please type it into the Q&A box, and you can find that at the lower part of your screen. So first, we're going to start off with a question for Dr. Dykes, and then maybe Dr. Holbein can chime in as well. But what do we do when a doctor does not seem to offer supportive transition or is not willing to give my teen a little bit of TLC and a team approach to care?
So I think you're always going to find relationships in life where people don't always do things exactly like you would plan. And so, if that happens, I think that there are resources that you can work on between visits. So the group of things that we were talking through is on the NASPGHAN website. That NASPGHAN is our Pediatric GI Society, and there's a list of things for doctors and for patients to start to look at in terms of things that you could look at. And like Dr. Holbein was talking about, there are things that you can do, just encouraging independence at home. Most of the work of transition doesn't happen in the visit. It happens outside of the visit. So I think as a parent, trying to not speak first and things like that are always hard to do, but trying as much as you can to give moments for your child to speak is helpful. I had some interactions even just today where I tried to talk to the patient and the parents were talking, and it's hard because we want to hear from patients, and it's hard as a parent to not speak up because I have 2 kids. I want to answer for them, especially if I don't think that they know, but sometimes learning how to do that is really, really difficult. So it is a process, and I do think it's okay to bring those moments up with your doctor and say, I'm going to step out for a little bit and stuff like that. And I don't think that they would mind it. Some people just don't think about it. They get busy, and they have other things happening. So it's okay for you to bring it up. And I don't think anyone would mind that.
Awesome. Thank you so much for that. And then for this next question, we're going to start off with Dr. Holbein. My 17-year-old is on infusion therapy. What age is appropriate to transition this responsibility to him? He will also be going to college in the fall 2025 and still seeing his pediatric GI doctor. Should he transition to an adult GI pre or post college, especially if he's attending college out of state or out of the region?
I just want to make sure too that I heard correctly. Did you say infusions?
Yes.
Yeah. So, I think that again, it's thinking about what specific aspects about infusion treatment, some of the different things that go into coordinating infusion treatment. So, at least at our center, I think about, the scheduling aspect, the even just like keeping it on our insurance. I think it depends on where um, your team may already be in that process. But again, it could just be starting with, hey, we need to talk about how often, we want to make sure they know what their frequency is for how often they're getting their infusions. And then working on scheduling or even working on the check-in process, right? Like the check-in process might seem like it's easy or that we're used to it. And yet like a teenager might not know that there's a copay or what questions they might ask. So it may be that they're again watching that first time and really we're making a pointed effort to say, hey, like let's watch it check in. And then maybe next time, as Dr. Dykes was just saying, as a parent or caregiver, we're kind of like stepping back for a minute and having them answer the questions while we're standing beside them to help out if there's any curveballs that they get thrown. So I think again, it really is about breaking that up and working on some of those sub goals. As far as, I think, I can also defer to what Dr. Dykes thinks here as well, but for a lot of the young people that we see at our medical center, asking about when to transition and what each practice's policies are really matters. So there are some medical centers that may have a hard and fast age that they use to make that cutoff, and others where it might be a little bit more flexible or they have a little bit of a different policy. So I think asking those questions can be really helpful to identify, what that looks like, what the timelines look like, and if it would be helpful to also have, in some cases there may be some shared care where there may be, the primary work with the pediatric provider for a year or two, and then a local provider as a backup in case something happens when they can't necessarily get back to their pediatric GI team quickly. But Dr. Dykes, you might have a different thought about that.
Yeah. I mean, so there's no easy answer for that. But there are some groups across the country that have to transition at 18. They're not allowed to see past. Some are 21, some are 22, some have capability of seeing even past 22. And with our practice, our hospital isn't able to admit patients past 21, but our office can see people past 21. But there are certain insurance providers locally that won't let patients continue to come see us past 18 because they have adult GIs available after 18. So we've been surprised recently that like all of a sudden on people's 18th birthday, I can't get infusions covered anymore and I can't continue to take care of them because they are magically an adult at 18, which is unfortunate. So sometimes even with the best of intentions, things get confused. So my practice is usually to try to keep people through college unless they are going so far away that it makes things difficult. And so often what we'll do if people are going far away is find a local doctor, in Chicago, in Florida, wherever they are. And then we still are available when they come home for summer breaks, and we'll just kind of co-manage when they're in college because realistically, 80% of their life is away from Atlanta. And, we can't do everything if they're far. We want them to have an emergency doctor. My general rule is I don't do pregnancy. I try not to do, things like that just because it's not good for mom and baby. If people are doing adult things and they're getting a job and adulting otherwise, and that's a good developmental transition moment or transfer moment. But a lot of times it's patient specific. We don't really have a hard and fast, you have to go at this age because everyone has a little different situation.
Thank you for that. And then I think we have time for one last question. So I'm going to direct this to Dr. Stropel. Is it okay for a parent to accompany their teen to their first adult practice appointment, even though they're the ones taking the lead?
I think it's very much okay. Many times we have focused on family-based care and pediatrics, and certainly I think adults are very much comfortable having partners there, spouses, other family members there. I think the most important thing is that the discussion is led by the patient. The patient has time to ask private questions, so there's time alone without the parent in the room, and all the discussions and questions regarding foreign care be directed by that patient and that visit. And the parent being a support more and an advocate more than directing the care, if that makes sense. I don't know if Tina or Shelley says anything. I agree that the timing of transition is variable and patient specific. I think the hardest thing is you never want to do a hard transfer. You always want to have the skills developed so that if they have to transition to or transfer at 18 years of age, they have those self-management skills, even if it was not anticipated. I don't know if anybody else has a comment about being in the parents being there with it. I think it's 100% almost anticipated by many of our adult colleagues that see young adults.
I would think so. I mean, I think, they're always going to want to try and direct things at the patient, but I don't think anyone minds having an extra set of ears. I mean, my husband's a grown-up man, he's 45, and he always gets things wrong when he comes back from a doctor's visit without an extra set of ears. So I think it's always good to have a little extra help.
Thank you
very much
all.
agree.
Yeah, this was a great discussion and we learned some helpful information today. As our program will come to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit some of our helpful educational resources that are listed below. And then along with the foundation's resources, we encourage additional resources from other organizations that could be helpful to you or your loved one as well. And then to watch any of the previous webinars and expert conversations, you can visit crohnsandcolitisfoundation.org/myibd learning. I think we mentioned it a little earlier. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback and it will help us plan future programming. And so with that, we want to thank you all for joining our MyIBD Learning virtual program, promoting IBD independence in children and teens. And we hope that you all have a great rest of your evening.